Assalamu alaikum dear doctors. In this video I am discussing about Henoch schonlein purpora history, HSP. So HSP history, it is an immunoglobulin A mediated vasculitis, we all know that. And the features are there is hypertension, arthalgia, limping presents, there is purpura, that is rash present, urine dipstick, hematuria can be present, immunoglobulin nephritis. And normally the chief complaints of Henoch schonlein purpura come in exam like Omar, 8-year-old, 1 week complaints of fever with rash. So 1 week complaints with fever with rash, or it can become as complications like 12-year-old boy with 1 day history of hematuria or limping starting from this morning. It can become like that way. So when before you starting the history fever with rash, that is 1 week, that is acute history. So acute DDO fever with rash are come on exam are Henoch schonlein purpura. It can be ITP, meningococcemia or meningitis. It can be Kawasaki disease. It can be PIMS and child non-accidental injury, abuse, bruise. So these are the acute history we keep in our mind and targeting these questions of this DD we search. Now history of present illness, that is analyzing the chief complaints plus review the systems. So our chief complaints is fever with rash. First fever, we ask about the onset, course and duration of the fever. Is there any diurnal variations, measurement method, medication given, associations associated with rigor, night sweating or any abnormal movement. Did they all come together, the fever and the rash we ask. And then rash we analyzing, what are the question we ask, the onset, course and durations, when started the rash, describe the rash. Like it is a raised on the extensor surface of the legs, buttock and arms and surrounding erythema. So remember Henoch schonlein purpura, that is one of the features, diagnostic feature is the rash. It is on the buttock, leg and arms. And the distribution is very important. Is it elevated? Is it itchy? Does it disappear when you press on it? Oozing or not? Punched out lesions, crusting or not, and color of the rash we ask. And other concerns we ask like any dysmorphic features and any chronic illness he is suffering or not we will ask. Then systemic review from MSK we can ask any muscle pain, skin lumps, neck swelling, size, mobile, red, hot or painful we will ask. Hair, nail, lip swelling, hand swelling, peeling of the skin of the hands or feet, bone pain, joint swelling, redness, number of joints affections, limitation of the movements. So another complaint, it can be associated with limping. We know that Henoch schonlein purpura, that is arthritis also present. And here they mention the peeling of the skin of the hands and feet. By these questions, we are differentiating the Kawasaki disease. The DD is excluding. Now, after that, we ask the general conditions. General like fever, is it associated with fever, weight is affected or not, any activity, sleep affected or not, appetite, these are. Then one by one the systemic review. In systemic CNS, we ask like, was vision affected? If affected, is it unilateral or bilateral? Redness of the eyes, hearing, fits, bug in the brain, decrease the consciousness level, increase ICT sign, any abnormal movements, weakness, abnormal behavior and hallucinations. So decrease the consciousness level, lethargic, any bug in the brain, these are we asking. That we know that meningococcemia is another condition, but in meningococcemia child will be lethargic, there will be headache and the features different. Now chest we can ask the recurrent bug, any cough, dyspnea, musical sounds, contact with COVID, smell lost. CVS we ask like any heart racing, blood pressures, exercise intolerance, awareness of the heartbeat and pallor. GIT we ask the tummy size, pain and its severity, poo, sore throat, lip fissures or peeled, taste lost. Urinary we ask the pee, change in color, odor, blood, burning sensation, frothy pee, pain in the private area if male, orchitis and blood pressure measured. So this is important because hematuria sometimes develop in Henoch schonlein purpura, and also the frothy pee, there pain in the private area in male. Yes, orchitis develop and anyone measure his blood pressure or not. Sometimes hypertension presents. And hematology we ask pallor, bleeding, bruising, bug. Endocrine we ask anyone measure the blood sugar. About the past history, we all know that the mnemonic is 5TIOA. So 5T traveling history, treatment, he is taking any treatment or not, any trauma, any surgery have done or not, any team he is following or not, any blood transfusion, these are. So traveling to any endemic area as rash is present, mosquito bite, malaria, tick bites, Rocky Mountain spotted. Then parental history we will ask as usual, puberty, vaccination we are taking, allergy, if atopy ask in details, allergic marks. The nutritional history, development history, growth charts we ask, family all. Does any family member has current COVID? Also about their vaccination status or mouth sores, herpes, eczema, herpetecum, that is also we exclude. Then social, financial and home school. Last days in nursery, if less than 2 weeks lies with the, if more than 2 weeks no need. And psychological and impact, how does his condition affect the family we ask. I am telling the differential diagnosis is fever with rash. So these are infectious cause, rheumatological cause, vasculitis and hematological cause. Infections are dividing by bacterial and viral. Bacterial are scarlet fever, that is a group A streptococcus, meningococcemia, group A streptococci, staphylococcus scaldal skin syndrome, impetigo, infected eczema, infective atopic dermatitis, Lyme disease and cat scratch disease. So in rash you can ask any pets present or not as cat scratch disease. Then viral cause like COVID, parvovirus, MMR, roseola infantum, that is 6 disease, HHV6, chickenpox, varicella, herpes simplex, eczema herpeticum and malaria. Now rheumatological cause are SLE, GIA, systemic onset and rheumatic fever. Vasculitis, that is Henoch purpura, Kawasaki and PIMS. Hematological ITP. NAI and abuse should be put in consideration in any case with bruises. So among them, what history come in MRCPCH clinical? These are come like meningitis, meningococcemia is coming. So we need to learn. We need to learn HSP, Kawasaki, PIMS, ITP. All are coming. And on chronic rheumatological, both 3 are coming. SLE, GIA, rheumatic fever, 3 are coming. And NAI is very important, child abuse. It is also come on the history. Discussion of Henoch purpura history. What are the questions that can be asked? All are from guidelines. First investigation, what investigation we will do? All patients we do number 1 blood pressures, number 2 urine dipstick, number 3 if proteinuria, send urine for early morning protein and creatinine ratio. Number 4 if hematuria, send urine for microscopy. Additional investigations is blood test if urinalysis abnormal or diagnosis uncertain. We do the full blood count plus film, urea electrolyte and albumin. Then if fever, blood culture and ASO titer, coagulation profile, throat swab. Indication for admission. What is the indication of admission of Henoch purpura patient? Number 1 if orchitis, number 2 moderate or severe abdominal pain, number 3 arthritis involving more than 2 joints, number 4 proteinuria, number 5 clear evidence of gastrointestinal bleeding and number 6 inability to ambulate. Now what is the indication of refer to rheumatologist if atypical or rapidly evolving rash? We refer rheumatologist. An important question is refer to nephrologist if when. Number 1 urinalysis blood or early morning protein more than 1 plus after 6 months. Number 2 macroscopic hematuria or heavy proteinuria at presentation. Number 3 hypertension, see hypertension guideline. Number 4 significant proteinuria, early morning urine protein in creatinine ratio more than 100 gram per millimole or 3 plus proteinuria for 3 days. And number 5 is impaired renal function. About the treatment. What is the treatment of Henoch purpura? Admission if needed, we admit. Then joint pain, we give the NSAID. Ibuprofen is first line. Use it caution if renal involvement or patient asthmatic. For abdominal pain, number 1 give prednisolone 1 mg per kg per day, maximum 60 mg per kg for 2 weeks. Number 2 renal involvement, not a contraindication. Number 3 if severe and persist, exclude the pancreatitis, intersusception or spontaneous bowel performation. Monitoring, how can we monitor? First of all, uncomplicated Henoch purpura. If it is uncomplicated, example urine analysis is less than or equal 1 plus blood and protein and normal blood pressure, no hospital follow-up required, but GP follow-up up to 1 to 2 weeks, monthly blood pressure for 6 months and weekly urine dipstick at home until urine is clear. And Henoch purpura with hematuria or proteinuria more than 1 plus and normal renal function. So complicated then as above plus routine follow-up in children's outpatients. Now discharge and follow-up of Henoch purpura. Inform the parents condition may fluctuate for several months but recurrence rare once settled properly. Very rare risk of renal failure, that is 1 to 3%. Remember they ask risk of renal failure is 1 to 3%. Hence importance of monitoring urine. Seek medical advice if child develops headache, rectal bleeding or severe abdominal pain. And uncomplicated Henoch purpura GP follow-up as above. Discharge from the GP follow-up if urine analysis and blood pressure normal 6 months after onset. So this is all about the history of Henoch purpura. It is very important. It also comes on video station and communications. Please do subscribe and share. MRCPCH with Dr. Emma Choudhury. Thank you.